Your attention, we're going to get started. You can continue to, I am going to get your attention now and have you quiet down a little bit. We're going to get started. I want to welcome you all to the University of Scranton this morning. My name is Julie Schumacher-Cohen and I direct community and government relations here, and glad to have you all here for our fall community breakfast. I think it's almost fall actually, so that's good too. And especially glad to welcome many friends and colleagues from the Scranton community. We're here this morning for a topic that is of importance to, of course, big cities like Boston, but also to smaller communities like our own here in Scranton, and that is how to care for and accompany our homeless neighbors. And we have someone with us who has been at the forefront of this work in Boston for decades, Dr. Jim O'Connell. I had the opportunity to read his book over the summer, Stories from the Shadows, and of course our students were required to read it as part of the Royal Reads program. It's a wonderful book, so I do recommend it if you haven't had a chance to, and we will have a book signing at the end of the program. But he really brings you along as he is walking with and among those who are most often at the furthest margins of our society, who he often describes as rough sleepers. And the book has many occasions to get a sense of the trials and the traumas, but also the courage and the humor. You laugh a lot in the book, and you really get to know his patients. So Dr. O'Connell is going to share a presentation this morning. He's also very happy to take your questions, so we really hope we can have a discussion. And our discussion does come today as we continue to grapple locally with how to, again, care for homeless individuals in our area. At the start of the year, the count of the homeless population in Lackawanna County was nearly 200 individuals, and 59% of those in our region who experience homelessness do so as part of a family, which is a little higher percentage than nationally, and that includes many school children. So we will actually be hosting a State of Scranton seminar later in November to invite local agencies to talk about the work that you're doing and really to kind of continue the conversation and think about how we can work together. I want to give a special thanks to the College of Arts and Science, and Dean Brian Kniff is here. They are the co-sponsor for today's event, and also to Dean Deb Pellegrino. We're in her building today, and also home to our Leahy Clinic, so thank you also. But I also wanted to just take a moment to remember someone who's very dear to us, Rebecca Haggerty, the former Assistant Dean of the College of Arts and Sciences. She was someone who was a key organizer of the Ignatian Values in Action lecture, and so events like the lecture last evening, but also the breakfast today. I would usually plan this event with her, and she passed away from brain cancer this past spring. So just wanted to take a moment to remember her, and maybe if you can just take a moment of silence with me now. Thank you. And also glad now to have with us today Sister Therese Marks. She was supposed to say the prayer before the breakfast. You guys all jumped the gun and got up and ate, so I guess you were really hungry. But we're really glad that she's here. She has been working with homeless women and children in Lackawanna and Luzerne counties for 24 years. She's retiring this month, but we asked her if she could come this morning and share a blessing over our time together and the food we've already eaten. So she's going to come up and say a prayer.
Thank you, Julie. Good morning. Let's just place ourselves in God's presence for a moment, still our minds and hearts as we pray. Dear Lord, as we gather here today, we offer thanks for Dr. James O'Connell, whose desire to serve you led him to the streets of Boston to start working with the most chronic of the homeless people in that city. In the beginning, in 1985, he had to let go of many preconceived ideas, as we have to also, both of the homeless and for him, for his training as a doctor, as he spent almost 2 months soaking the feet of the homeless at the nurses' clinic at the Pine Street Inn, where he was advised, just tend to the feet and ask what else you can do to help. In John's Gospel, we learned that you, Jesus, also washed the feet of your disciples. A simple task with a profound meaning. I have set an example in order that you may do as I have done to you. Dr. McConnell's education in homelessness and poverty at that time had just begun. And now we're here today after so many years in which he has worked so tirelessly, and we'll hear a lot more about that today. Over these many years, Dr. O'Connell earned the trust of some of the most needy men and women, whom society so often looks upon as outcasts. And he has compassionately searched them out on park benches and in alleys to serve to their medical needs and to offer them caring and realization of their dignity as human beings. He has illuminated the humanity and raw courage of those who struggle to survive and find meaning and hope while living on the streets. Today, Lord, we gather here to learn from him and to offer our profound gratitude to you for gifting him with such courage and compassion. Amen.
Thank you, Sister Therese. And Sister Therese is retiring after her long work for many years this month, so we congratulate her on that.
Thank you very much. I'm actually still staying on for a while because we're not going to do executive director with us, so we can start one more step. This is a good opportunity for you to meet her, we welcome her, and we thank you for your continued support.
Thank you. So let me just take a moment also just to recognize some of our guests in the room. Of course, we're pleased to have with us many colleagues from the healthcare sector and nonprofit organizations and also economic development agencies. My own pediatrician, Dr. Doggart, I see in the crowd. Not my own, my children. Staff representing the Office of State Senator John Blake and Lackawanna County. We have former Scranton Mayor Gene Peters. I believe I saw him come in. And Board of Trustees member Tracy Bannon is with us. Thank you, Tracy. And also with us this morning, we have a table full of Dr. Kim Pavlik's students. They are her communication students, if you guys want to raise your hands. And I always like to alert the audience that they are in her news writing class. They're going to be live tweeting today's event. So they can be on their smartphones throughout the event, and they'll be sharing what Dr. O'Connell has to say with the wider world. So you can always check them out on Twitter later this afternoon. And now, to introduce our guest speaker, I'm very pleased to have with us a student from the College of Arts and Sciences, Michael Preddy. He is currently a graduate student in the Masters of Biochemistry program. He's also a 2017 grad in Biochemistry, Cell, and Molecular Biology. So he's very busy studying, I'm sure, a lot, but he's also a very avid volunteer at many different community organizations. So he's going to introduce Dr. O'Connell. Michael.
Thank you. Okay. Welcome, everyone. I'm humbled today to introduce Dr. James J. O'Connell. Before founding the Boston Healthcare for the Homeless program, Dr. O'Connell received a bachelor's degree from the University of Notre Dame, a master's degree in theology from Cambridge University, and his medical degree from Harvard School of Medicine. After graduating from Harvard Medical School in 1982, he completed a residency in internal medicine at Massachusetts General Hospital. In 1985, Dr. O'Connell began full-time clinical work with homeless individuals as the founding physician of the Boston Healthcare for the Homeless program, which now serves over 13,000 homeless people each year in 2 hospital-based clinics, Boston Medical Center and MGH, in more than 60 shelters and outreach sites in Boston. With his colleagues, Dr. O'Connell established the nation's first medical respite program for homeless people in September 1985, with 25 beds in the Lemuel Shattuck shelter. Today, he and his team still work with homeless individuals at Boston Healthcare for the Homeless program and in clinics at Massachusetts General, providing medical services to the homeless individuals of Boston. In his book, Stories from the Shadows, Dr. O'Connell shares the stories of the marginalized, the people who are not heard in society, not because they don't have stories to tell, but because there's no one to listen. The disconnect lies in our lack of empathy and our failure to imagine what life must be like for someone else. The images of poverty are inexplicable, but we choose to ignore them because we don't want to feel depressed or unsettled. Rather than suppressing this dissonance, we should let our unsettled conscience drive us towards social justice. All around us, there are people who feel alone, ostracized, and forgotten about. It is our duty to care for them and to remind them of our shared humanity. Nobody deserves to die alone. After reading Stories from the Shadows and attending the Street Medicine Institute in Allentown and speaking with Dr. O'Connell, I have developed a strong vocational desire to practice street medicine and serve as a proud advocate of the movement. You might ask, what is street medicine? And I'll pass out packets on it as well. But street medicine is a movement geared at bringing healthcare and support to those who need it the most. Not only has the practice of street medicine cultivated a network of support for the homeless, but it has also saved lives through preventative care. Through an administrative perspective, it has saved hospitals millions of dollars by decreasing ER visits. I may have a quixotic vision of beginning a street medicine program in Scranton, and while it may take a lot of time and effort, I believe it's worth the pursuit. The practice of street medicine is not just limited to doctors, physicians, nurses. Anyone, and I mean anyone, can play a helping role. Everyone has the ability to serve in by their unique capacities. A few students and I have been working to set up the groundwork for a street medicine program here in Scranton. If anyone has any advice or is interested in helping to set up a street program in Scranton, feel free to talk to me or leave your name and email on the contact sheet that I left at the table. We have the power to create a better future for one another and advocate for the unheard. Go to the people. Thank you for your time, and it is my honor to welcome one of my biggest influences, Dr. James O'Connell. Thank you.
So that was thoroughly embarrassing. Thank you very much. Okay. So I'm still sort of in the glow of having spent yesterday at the university, primarily with freshmen, but also with some upperclassmen. And all I can say is that it was just a breath of fresh air for me to be here. So to step back from Boston and all the craziness of the city, to see a place like this where reflection is part of what you do, and a city that feels so kind of welcoming. It's my first time ever in Scranton, by the way, I'm embarrassed to say, but you have a gem here, and I'm sure you have all the problems that cities have, but it feels like your problems don't seem to divide you. It seems to bring you together, which is something I really, really admire. And thank you. I hope whatever it is you're thinking of, the people in town will really help you with, and I have a feeling they will. I didn't know quite what to do, but I wanted to show you a couple slides just to get a discussion going. And so please, if you have a question or want to interrupt, please do that, because it's a little awkward at breakfast trying to keep everybody's attention. So this is a picture that, believe it or not, it sort of has meant a lot to me in my life. I promised it was a homeless woman who took this picture, and I promised her I'd show it whenever I give a talk, I'd throw it into the talk. But she lived under a bridge. It's called the Longfellow Bridge. If any of you have ever been in Boston, it's called the Salt and Pepper Bridge. It spans the Charles River from where Mass General is over to Kendall Square, which is now becoming a really hot biotech center. But she lived under that bridge, up in the rafters, for about 10 years, suffered from all the things you can imagine. She has AIDS, she has hepatitis C, she's got diabetes, and she's struggling with several addictions, etc. So we would take care of her under the bridge. But one day, she had a throwaway camera, and she took this picture of her close friends. And these are, when we use the word rough sleeper, it's kind of a euphemism that comes out of the English literature. People who really do sleep rough outside. They don't go into the shelters, they stay out. And these were her friends, and I think there's about 11 or 12 men there. There's actually one woman who's hiding. She's the one bending over so that she wouldn't be the only woman in the picture. And so she took it, and it was right at the turn of the century. And I never saw it. She never showed it to me. But about 5 years, exactly 5 years after she took the picture, she was very sick, had come into our respite program and was going on for some surgery. And so she asked me if I'd hold on to her stuff. And she showed me the picture, then it was 5 years. And I looked at it and I was kind of stunned because I've been a doctor taking care of the street folks for a long time. So I know all of those people. They're all really colorful characters. They can be feisty and ornery and, get you angry day in and day out, but mostly they're kind of lovable when you get to know them, okay? But I looked at it and I was stunned for a couple of reasons. One is that at that time in 2000, we had already expanded Medicaid, and all of those men whose average age is in the mid-30s had Medicaid. They had full insurance, so it's not an uninsured population. The second thing, which was even more embarrassing for me, it's a picture she took of them sitting in a park where many of them hang out, but the park turns out to be on the grounds of Mass General, which is my hospital. So I was thinking, here's a pretty fully insured group of people sitting pretty close to a darn good hospital. And when I looked at it 5 years later, there was just one of those people still alive. Okay, and as we've begun to sort of look longer term at what we see every day, we're realizing that it is devastating to be sleeping rough on the streets of our cities. And the leading cause of death for these guys, and they're only in their 30s, remember, was cancer. It was not by far, it was cancer. It was cancer and heart disease. It wasn't hypothermia or the things you might expect that people on the streets would die. They were dying from really significant medical problems. So I saw that picture. When I saw that, I was horrified because it brought back the stories of many of these people. But it also was kind of an indictment of our own system. So here I am living in a city that's pretty tiny. Boston's about 2 miles by 3 miles, so it's not very big. And we have 12 academic teaching centers there. We have 3 big medical schools, Harvard, BU, and Tufts. Innumerable community health centers, really good ones funded by the federal government. Yet we have people dying in the shadows of our own hospitals. So that was the dilemma. We figured out, what do you do about that? And it's a real challenge. And what we've learned is the challenge is, to some degree medical, because we'll try our best to do what we can medically. But I've come to realize, as I'm sure all of you, that this is a challenge that hits all sectors of our cities and towns. It's the schools, it's the police, it's corrections, it's labor, what your labor policy are, it's legal stuff. So when you start to think about solutions to this, we realize it has to bring us all together. It's not going to be solved by any one of us. We used to think that housing was the real solution, and many people will still advocate for that, which we desperately need. But housing alone isn't even the solution, because the problems that have caused these folks to be on the streets don't go away just because they go into housing. They need housing with a lot of support. So all of these things are percolating through, and you'll see this all over the country now. And as speaking now 34 years into something I thought was a temporary problem we were going to solve after 4 or 5 years, we failed completely. And now you see homelessness, particularly in urban settings, growing really scarily as the income gap gets bigger, as it gets harder and harder to get an apartment in your cities, you're starting to see more and more homelessness. So that I would just share with you as kind of the, if there was something I would urge you to be able to do, is get together and look at these problems as a citywide solution, if not a statewide or a federal-wide, but certainly at a city level, we need to get everybody together. And I wanted to show you a couple of other things. I guess I got to leave this out here. And the second thing that, if you have a chance to read the book, and I'm thoroughly embarrassed, by the way, this book we sort of published for the 30th anniversary of our program, and I did it under great duress because I have a board of directors that was putting the whip to my back to say, get this thing done by a certain time. And what we learned a very long time ago was that involving the people you're serving in the services you're setting up is probably the most important thing you can do. So we had and sister, by the way, thank you for that word. Thank you for that wonderful prayer. But as you wouldn't be surprised, we had a couple of nuns back in the beginning who happened to be Sisters of Mercy and Sisters of St. Joseph, who beat us up. I'm trained. I had 8 years of Sisters of St. Joseph in grammar school, Christian Brothers in high school. So I've been inculcated in all that. And their mandate was that we didn't know what people needed. The people who are out there know what they need, and you've got to involve them. So there was a mandate in our program that said that we always had to involve homeless people, the people who are serving, in the design and the implementation, and actually also the governance of our program. So on our board of directors, which is, a mixture of lots of different folks as you would be used to with boards, but we have about a third to a half of the people are homeless people. And that has been, I could talk to you for hours about the experience we've had because we have those folks on our board. So they literally hire and fire us, okay, when you think of that. So when we're serving people, we're serving the people that really are telling us what they really need. Anyway, this is a picture I took a long time ago of 8 of the members of our board of directors who are all homeless and have lived, they were all still currently homeless. Many had lived on the streets for years. So anytime we had an idea of a program or a new thing we wanted to do, we had to get it by them. And they were pretty stern taskmasters. And one of the things they said, which has lingered with us forever, is, and this goes back to 1985, is that they were annoyed with us as doctors and nurses for staying in the hospitals or staying in our clinics when there are people struggling outside who can't get to us. So how do we get the services, and you can expand this from health to anything else, out to where people are? And that was the first challenge, I remember that. And then they said something really interesting. I'd share this with you because I've struggled with that early on. So I took this job back in 1985 because my chief of medicine basically conscripted me, and the city had gotten a grant. They needed the community was demanding a full-time doctor. They couldn't find one. So he called me in and said, would you do this for a year? And sort of like being called in by the principal in grammar school, there's no way to say no. These are rhetorical questions. And so if I valued my career, I was going to do it. So I figured, what the heck? I went to college in the 60s, and this was going to be my chance to give something back. And I was going to do a year of Urban Peace Corps. So I went down to start working at the shelter, and that's when I had to do 2 months of foot soaking. They wouldn't let me do any doctoring. And it was all, they were going to ease me into what this is all about. And I'll never forget thinking about what a mistake I had made, for the first few months of oh my God. But what they were pointing out was that they thought healthcare, like so many other things in our society, should be a matter of equity and social justice. It shouldn't be an issue of charity. Although sometimes all we have that we can give is the charitable response. And I'm a huge believer in that, so not to say that. But they weren't, at that time, they were interested in getting justice. So they wanted to have the same kind of health care that everybody else had. So when they looked at me and I said, well, I'm here, I'm going to give it everything I have for a year, they said, but wait a minute, this is all about continuity of care. And they said, if you're going to spend a year getting to know all these folks who have been scarred by their experiences on the streets and everywhere else, you can't just get up and leave after a year because people will have opened up to you and trusted you. So this kind of tension began right from the beginning about how do you make this not something you just do for a month or 2 or 3 or a year, but something you can commit yourself to. And I was in no mode at that time to commit to anything longer than, and my whole life had been a series of this, and that. So that was the challenge I can remember running into, because they wanted to know if they were sick if they saw you on a Monday or Tuesday but got sick the next Friday, they wanted to be able to get a hold of you, and you needed to know them. So one of the themes of our program, and something I would share with you that we were talking to the students about yesterday, is that how do we provide avenues for people who are interested in caring for these folks in whatever it is, but to continue that as a career rather than as just something you do as a good work. And it's a struggle we've had in global health. As many of you may know, one of my close friends is Paul Farmer, who has done Partners in Health, and that's a challenge also when you go overseas. So just to look at it as a gold standard, I throw that out there as a matter of discussion. How do we set it up so these provide continuity of care so that people outside who finally can open up and trust you will know you're going to be there, or the team that's caring for them will be there. So that's more preaching than I'm sure you needed to hear at this time. But I threw in a couple of pictures of our favorite. In that, this is, and I thought this was fair to show here because we get snow too, not as much as you do, but we get some pretty bitter cold nights. And we have about 300 to 400 people who stay outside on the streets of Boston all year long. They will not go into a shelter. We have a shelter bed for anyone who wants one. The mayors have been very good about that. But there's this subgroup of the population that Mike so wonderfully articulated, who won't go in. They stay outside. And the challenges to care for them are immeasurably more complicated. But this is a couple who we've known for 25 years, they're just delightful, but they will not come in, even in the snow. They were sleeping right there where I'm showing you. And this is a woman who is 92 years old and staying outside. And this is how she slept each night. This is a sort of in the early morning when we were taking the picture on the van. And I highlight that to say that the challenges are often, not just in the one-to-one situation, but how do you set up, sort of places for people to go and legal options that people can be brought in. We struggle all the time about, is that someone, I looked at that woman and realized she was somebody's grandmother and sleeping out in the cold like that, but didn't want to come in. And then when can you say, no, this is not good, we have to bring you in? So that tension of when is somebody's thought disorder so bad that we need to bring them in against their will versus letting them have their own free will and they can make their own decisions. So we spend hours in each week trying to struggle with this. But then the other thing that I just wanted to show you this, I haven't looked at this picture in a long time, but this is a man who we knew who slept in a back alley and down in the beautiful part of, there is a beautiful part of Boston called Back Bay, and it's near the downtown, and he slept in one of the alleyways behind these two beautiful streets, Newbury Street and Commonwealth Avenue. And we had taken care of him for years, and we knew him in one vein, but I realized even when we thought we knew him, when he died, a whole community sort of came out to respond to his death, because what we had not known is that he loved dogs. And he would do anything he could to get food for dogs. And when people would be walking their dogs in that area, he knew every one of the dogs' names. And then he befriended the people who were there, and they loved him. We had no idea about this. So when he died, I remember there was an obituary in the paper, and the community, this is a Back Bay community, had a funeral for him. And this was a funeral at the funeral home at Kenmore Square, which is, the funeral home in town, all these flowers. And we were stunned. We thought he had been all alone, living in a back alley, causing a lot of trouble all the time. And then this was a funeral. After the funeral, this is one of the priests standing on a thing, and they dedicated a park bench to him at the end. And so at that funeral, I remember being there. It was a Saturday morning. There were lawyers and doctors and, IT people. It was quite extraordinary that it was the community coming together, all of whom knew and kind of cherished this man, but all of us had collectively didn't really know what to do for him other than to help support him. But it was my first vision that we will solve this only when we're all sitting together realizing this is a tough problem. It's complicated. It's not political. It's just very complicated, and we need all of us together to work on it. There was even one of the columnists in the Boston Globe, did a big article about him, and we were all stunned after knowing him all that time. This is the park bench that was dedicated to him. And then just another picture, and I'll stop after this because one of the themes of my learning has been that first impressions are rarely what turns out to be true. And most of the time with homeless people, you walk by and you get that first impression, and that kind of lingers with you. And so what I remember, these are two people. This is at our Mass General Clinic, which is a Thursday clinic dedicated to the people living on the street. And one of the nice things is when these folks come into the hospital, they feel entirely stigmatized because they haven't had a chance to change, they haven't had a chance to shower, they don't feel comfortable in those crowds. And hospitals are really kind of, to them, hostile environments. Yet so many of them are so sick, we really need to be able to get them in for their exams and their imaging and stuff. But anyway, these are two guys who most people thought were just pains in the neck. And Greg is the one on the left. And Greg is I grew to love him. He's a big kid, not a kid anymore, but he has a dense stutter. When you try to talk to him, the more excited he gets, the more he has trouble saying. And when he was growing up, people made fun of this stutter, so he was always getting in fights with other kids, and he was labeled a real troublemaker. And on the streets, you just knew that be careful, he might fight if you're not careful. And so we were like, this guy's really ridiculous. And it turns out I met him in 1986 when he was sleeping under one of the bridges with his mother, okay? And his mother was there and his sister, and they were all living under the bridge. And as I got to know him, I saw that he was kind of rough and never very kind or anything like that. But one day he got sick, and I brought him in, and he at least trusted me at that point. And through the stutter, I started to realize that he had never really gotten out of third grade. When he was growing up, he lived in chaos and real poverty. His mother was, his mother had terrible bipolar illness, was drinking and sometimes there and sometimes not there. So he never had anything straightforward. But I brought him in. He wanted to call the one sister he had who lived in lived in Roxbury. And so I gave him the phone and said, go ahead, give her a call. And he kind of pushed the phone back to me and he said, can you do that for me? And I said, sure. And it turned out he couldn't read numbers. He couldn't read. He couldn't write. He couldn't even read numbers. And when we finally did formal IQ testing on him, his IQ was about 49. And so here's a kid who grew up in abject poverty, in chaos. No one had ever gotten him into services, and he was labeled a tough kid, never got through school because he can't read or write, doesn't have the skills. And now he's in his mid-40s, and what do? He doesn't have any skills. He's never had a chance. And his entire family is basically homelessness. So it changed the whole way we looked at this poor young man, and realized that he'd been through hell. And his buddy, who's Billy, who's equally irascible, equally lovable at the same time, and Billy's there because he was sick in the hospital. That's why he's got his robe on. And Billy is, he suffers from a little bit of everything. He's got AIDS, but we've got him on treatment, so he's at least doing okay. Has terrible heart disease, and has had 2 strokes already. And he's only, in this picture, he's only about 41 years old. And it turns out Billy, when he was 5 years old, he, by the way, was also labeled in the hospital. People hated to take care of him because he was always in trouble. He couldn't sit still. He wouldn't do anything you told him, all that stuff, including all of our staff. But when he was 5 years old, in 1968, he was in Roxbury when we had the race riots after Martin Luther King's assassination. And Boston had some pretty terrible race riots. And somebody poured gasoline over him and set him on fire. He's 5 years old. So what you can't tell here, and I never knew until we got to know him, is he's burned, his whole body is burned below his neck. And he spent his life basically in agony. Never really got to school. He spent 2 years in the hospital having at least 120 surgeries when he was all of 5 and 6 years old. And then the course of his life was set by that trauma. And once you understood that about him, everything changed. And he became, and as it turns out, we got both of these folks into housing eventually. And once you got to know them, everybody loved them and they did great. But it took us years to get through that thing. So if there's a theme I have, is sometimes what you have to stick with it and get to know what the stories are. But I have never yet seen somebody who's been living on the streets for like 6 months or a year who doesn't have a story of really unspeakable trauma, whether it was in foster care or in their own care, or whether it was in the school system or by drug dealers. It's trauma. And it was trauma that happened when they were back very young. So as we think about solutions, that's when I started to think, what we can do. We actually took care, they both have died now, and we took as good a care as we could for them, and I hope that they really had their suffering eased by what we were doing, but we didn't change the course of what was going on. The course for their lives was set back then. So I am now more and more thinking that we need all of us to be thinking about how do we fix early childhood intervention, how do we fix food security, how do we make sure that kids in school who have ADD especially in our poor areas, get the attention they need so the course of their life doesn't go a different way. So preventing homelessness, I think, is something that we all should be doing as a community. And I could go, I have no idea what time it is, but I'm looking at all of you, and I could give you story after story of that, but I'd much rather invite a discussion and just say that what I've learned I love my job. I get to take care of people who are incredibly grateful for us to be out there, as Mike knows. And it's kind of, if you're a doctor, that's kind of cool, that you're doing what you want. What I've had to learn is that you can take care of people we can take really good care of people, but we're just doctors. We're not going to change their homelessness or change the trajectory of what has caused that or not. So I think of our lives now as more witness to share with everybody that we really need to look at this from a societal perspective, not just a healthcare or just a housing or just a schools thing. So let me stop there, and I would truly invite any questions, and I also want to explore with Mike what his idea is about doing something here, but I'll leave that alone for now. Okay, but thank you. The other thing is thank you for letting me be here. It's such a treat to be seeing a city that seems so energetic and caring. Yeah.
I know you have to deal with what you're dealt, right? How much of this do you think is due to mental disease and the lack of mental facilities in this entire country?
It's a great question. We struggle with that all the time. One of the problems when you ask a question like that, but how many are, the problem is we don't know the denominator very well. So if you were to say, if I say, of the people living on the streets in a city like Boston, say you take our team takes care of about 800 people who have spent at least 6 straight months on the street or not. And when you say, what's the incidence of mental illness, significant mental illness in that group, it's well over 50%. So, and by that I mean bipolar illness or schizophrenia or really severe depression. So it's really significant, okay? Now, if you take all comers, we take care of in our program about 13,000 homeless people every year who come we have clinics in all the shelters. Many of those people have been homeless for less than a year or so. When you look at them, the incidence of mental illness is very, very low. So it depends on which segment of the population, but if you're talking about the people you tend to walk by and see outside, I think it's very high, and it's a huge challenge to take care of them. Great question, which we could go on about, by the way. But anything else? Yes? Yes, it's a great question. So the question is, how about veterans on the street? So when we look at and this is Boston, so I imagine every city will be a little different, but if you look at the adult unattached homeless population in Boston, 17% of them are veterans, okay? I can give you the exact number in the last count. One of the kind of interesting developments is because there's a lot of attention been paid to veterans now, and the thought of a veteran go over to war and then come back and being homeless is that's just not palatable to anybody. It's not a political statement or anything. So there has been a lot of money. One of the few places that people have been putting money into homelessness issue has been through the Veterans Administration. So if you look now, most studies, most housing, there are housing vouchers now for veterans. And so if somebody's a veteran, we can usually get them housed now because there's available money. That only applies to the veteran population, though. So there's been huge efforts to address that. But what it's done is emphasize for us how little we're doing for the rest. So it's a kind of a good news, bad news thing. But we're learning through the Veterans Administration some of the strategies that work really well and can be applied. It's just not a good environment right now for getting more money to expand that. A great question as well.
When you first started the work that you were doing, going out on the streets and tending to people's needs medically, how was that funded at that time, and then how has your funding grown to continue your program?
Yeah, that's a mean question this time. To make a very long story short, when I first started, I was a beneficiary. The reason I got asked to do this is because the city of Boston, along with about 19 other cities around the country, were given grants by the Robert Wood Johnson Foundation to try to organize care for homeless people. Now, they were relatively small grants. It's $250,000 a year. So we could hire people with that amount and then go out and do our work, and that was how we were funded. So what was nice about that is the thought was, you got to go find out what the problem is, go out there. So we were really given a mission to go out there, and we were paid. It wasn't volunteer, so it was a kind of nice. But happened for me, though, and the reason I got to meet so many of the people on the street is there was a van, I was mentioning this last night, that the state paid for. The state State Department of Public Health started to realize that the people on the streets were dying, particularly in the cold weather. At least they thought it was a cold weather. It turns out they die all year long. It doesn't matter whether it's cold or not. And the van goes out from 9 o'clock at night till 5 in the morning. And I just share this with you because it's very cool. It's funded by the Department of Public Health. It's run by one of the shelters called Pine Street Inn. And interestingly, when we were getting the van going in 1985, it was the winter of 85, 86, and the homeless people that were involved with this, we were telling them, what do you want? And they nixed, I wanted a medical van, and they had no interest in a medical van, much to my total chagrin. What they said is, when we're outside at night and it's cold, we want blankets and we want soup or sandwiches, we want food, we want clothing, and we want friendly faces who are consistently there. So the van is, and it's really cool, it brings those things to people around, and everybody who lives on the streets kind of cherishes the van showing up because it's there to give you stuff you really need. And it's not some doctor trying to talk them into taking their blood pressure medicine, So What has been great for me, though, the van is run by mostly formerly homeless people, and they're really the, what we would call in our world now community health workers. They were like original community health workers. And what I do, I go on Monday and Wednesday nights, but the price, it's sort of like soaking feet. I just serve food, I serve sandwiches and do that. But it was my way to get to know people. And now everybody sort of knows that on Mondays and Wednesdays there's a doctor in the van, so if you have any medical problems. And now, since I've been doing it longer than anybody else, I tend to know most of the people because it's just longevity. But it's, when the grant funding ended, the city and the state were so aware of how dangerous that was that they've continued to fund the van ever since that time. And our PEP program is now funded by the federal government under what's called the Federally Qualified Health Center. So the good news is we got funding after the grant ended. The bad news is we now have to do all the federal rules and regulations and all that stuff, which are, if we had started with that, we would never have been able to do the program we do now. Because we have it, we try to sustain it on that. So about 80% of our current budget is from Medicare and Medicaid. We don't ever bill any person, we just bill the government. Okay.
Dr. O'Connell, you mentioned that 50% of the homeless are mentally ill. How do you handle mental illness in that population?
Not well, but I can tell you what we do. I have this theory I've mentioned before that, when you go out to take care of a population like people living on the streets, a homeless population, and you just put on your healthcare lens, what they will do is they will show you the weaknesses in our healthcare system way before you have any idea it's a weakness, okay? And in the mental health world, it's glaring. So when I would see somebody who had bad schizophrenia on the street and would try to get them care, I'm an internist, by the way, so I do internal medicine, I would have to refer them to the Department of Mental Health, who would then have somebody do a screening, who would then give them an appointment 6 weeks from now to be seeing someone, and it never worked. So effectively, there was no service. So what we learned, and by pushing the hospitals primarily and the Department of Mental Health, so we have a full-time psychiatrist on our team who comes and shares in the care of everybody. And we've learned that's probably the only reasonable way to do it is you have to bring the mental health right to folks, and you have to go slowly. So I have pictures that I showed last night of our psychiatrist, who's this wonderful guy. He's just retired this summer, but he, most of his therapy was done at a McDonald's or at a train station, and he would sit and talk to people in settings that don't say anything about mental health or psychiatry. So we found that a lot of people who were resistant to care really were perfectly okay with it as long as you did it on their terms in their setting. But they won't go to any place that says, Department of Mental Health or Psychiatry Department or something like that. So we found that, for a good segment of the population, we're now able to do their medication management and their therapy out on the streets. There's still, though, a significant number of people who still don't see they have an illness and don't want to do that. And they're the ones that we still struggle a lot with about, are they doing okay or not? And that's a daily struggle. Does that answer the question? Pretty much on that. I think the integration of medical and mental health care and substance abuse care in a single team is mandatory if you're going to care for a population like that. You can't silo those cares. Yes?
I am from the County Office of Youth and Family Services, and some days I get to wear my Department of Human Services hat here in the county. And I have to tell you, you move me. I have some history in my life of people who I loved dearly, who were homeless, who overcame homelessness, and then found themselves in that position later in life again, and died early, uncalled for deaths. That being said, I kind of just glanced around the room to see if our social service providers, our mental health providers were here, and I don't see them. And I want to say that from the county side, we know, and I want to say that we hear that, and we realize that we need to take some steps towards leading to making sure that that is integrated care, that is integrated with our medical teams and our school teams and our county agencies, our Department of Human Services doing that work. And so I don't know if I have a question other than to say I am so grateful for the opportunity to hear you and be reminded, but also I've been in countless meetings just this week. Mike Hanley's looking at me going, you talk too much in these meetings, but countless meetings this week where The recognition of voice, parent, patient, family voice is key. We're working on that through our system of care effort, and that we hear the call from everybody else saying to us in the social service community, stand up, do your job, let's help these people, because it starts when they're 5 years old or 3 years old. And so we're here, we're coming, we're bringing people to the table, and if you need something from us, I will take all of your calls. And I will figure it out, and so will Pat and Bill and everyone else at our agency, because we get it. But thank you for that opportunity.
Thank you for what you said. I appreciate that. Yeah. While you're going over there, one of you guys has to teach me to tweet one of these days, okay? Is that okay?
I don't know it either. I'm curious to know, in your practice, you've met so many wonderful people. When you have representation on your boards, how do you go about selecting or asking them to serve, and what is the response, and when do you do it, and how does it go?
Yeah, I say that like it's just a question of putting people on your board. It's a huge, huge effort. And I pointed out I think the reward is really huge, but the effort is equal. Okay, so I'll tell you what we had to do. Because we had the mandate to do it, we realized most homeless people were intimidated by that. We have a budget of $50 million a year. We have, all these things going on, and that's hard to sit down and be on a board to do. So what happened, this is now in 1988, we decided to have a community meeting of any of our patients who wanted to come together to talk about what's working, what's not working. And that became kind of a Friday event that was really fun. And we provided a lot of food, and we just put a lot of effort into it. And people came primarily because of the food, and then they would also talk. But then from that, they organized, and we helped them organize what we call it's, for lack of a better word, a consumer advisory board. And that meets every month. And what we do is we bring them all to one of our facilities. We actually pay cab fare and everything to get them there, give them all $20 because we're taking their time, and we serve a meal. And that is the incentive for people to be there. And most people come all the time for that. And so we have a group of probably 30 real consumers who then meet once a month and talk and go over issues. And from that board, they elect the ones who will then come up to our board of directors. So there's kind of a learning process. And then once they're on the board of directors, they're always paired with another board member who then shows them through that. But believe it or not, once you've got done through that, but that took a lot of effort, then it's just fabulous. So I can give you an example of where the consumers became really important. So when I first started doing street medicine, and I guess I think of street medicine as an extension of what we were doing in the shelters, but it was really different. I was on this van waking people up at 2 a.m. to see if they're okay. And somebody said to me one night, "Hey, what the hell are you doing?" He said, "Would you want your doctor showing up in your bedroom at 2 a.m. saying, 'Hey, how you doing?'" And I went, "No, that's really invasive." So I had a crisis of maybe street medicine is not what we should be doing. Maybe we should be doing it differently. So I brought it to our community board, the consumers, and they called all the street people that were their friends together, and we funded it. It was like a 3-hour session. We couldn't be part of it. They just talked about it. And at the end of it, they came out, and it was really comforting. They said, "Look, we've decided if we're out there and it's cold, you should wake us up, to make sure we're okay." They really think that was important. But then they came back and said, "But with that damn flashlight you use," we use these flashlights when they said, "Would you just put that on your face, not on ours?" Because their vision is all they see is this light coming at them, and it's scary as hell. So it was really kind of a learning. And so ever since then, we felt like we've had their permission to be doing what we're doing. And that's where you can get some comfort. I was really frightened by all that. So just as an example of that. Thank you. Yes?
I was really touched by the way you talk about empathy and versus stigma. And I work in a county arts and culture department. With Lori, we sit on an arts engaged task force, and we're really interested in kind of what you're saying about how do you bring people together, really build community health, and also that idea of narrative mess, because it seems like the strength of your program is people getting to know people's stories and them as humans. And have you seen successes, or do you do trainings, and what are the platforms where we can bring so many people together, both to hear the voice of the people's and also tell our own story, so that it's less of it's more of a community where the boundaries don't exist? I don't know if that was a normal question, but basically, how do we connect with people better?
I think that's a great question. I think it tends to be, this is going to sound like I'm dodging your question, but it tends to be very local, and it tends to be just like healthcare. We realize that the way we deliver healthcare works in Boston, but it probably would never work here or in Philadelphia or something, because there's pressures on each. But I think I'm totally with you, by the way. I think when it comes to homelessness, narrative medicine is the entree into understanding what you then need to do, because you need to hear the stories in order to understand the complexity. And I am always fighting, when some of our folks go into the hospital to see a specialist, they see that person in an exam room for 20 minutes and they make these conclusions. And then we can say, oh, no, you don't understand. This is what they're going through outside, and the treatment has to be totally different. So what we have found is that involving, we have, and I don't know if this would ever work here, but the most important meeting we have, at least from a street perspective, is once every week we meet in a downtown place with the police, the EMS, the mayor's office, the community, the representatives from the community organizations, the outreach workers in our team, and there's state police as well. And it's to bring up the issues that are going on, okay? And where the police will see someone who's an absolute nightmare, somebody who knows them well will say, you know what the problem is, something's going on. And the police can say, well, can you go talk to them and get them to move, because we're being called to arrest them, So we learned in those settings, if you can find the right forum, then the narratives can come out in a way that everybody, so I think of it as changing it from a police issue to a much more public health and humanitarian issue. And when you've got everybody in the room, you can do that. It took us about 5 years to get that meeting to happen. But I would urge you to, if there's a way to do that, that's how to do it. The other thing that I really emphasize that I hope you're hearing, I don't know the answer to most of this, but it's complicated. But I do know if you go in saying, I'm not here I have no axe to grind other than we have these people dying outside, and how do we sort of work on that? And I don't have the right, that we could try lots of things, and learning to say, let's try this, but evaluate it, as opposed to the answer is you got to do this, which is always, we found, is like a showstopper for us. It just stops everything. So everybody getting involved in a process to work on this, because the goal is really to stop it. We just, one of our physician assistants who just finished her doctorate at the School of Public Health at Harvard and took the data we have on street people. And she looked at the people we've had for 10 years. And we've done a lot of studies on mortality, but when you look at the street population, just take that as a subcon, their death rate is 3 times that of people living in shelters. And the shelter people are already 4 times higher than the same age person living in housing. So as you start to factor out that kind of feedback, then makes people say, we've got to really work on this. Because, we have the same death rate on our street people as you would find in Burundi. Okay, so it's a third world issue that we're not addressing very well. And that actually, it makes the hospitals say they want to pay attention to that now. But without that kind of data, without that discussion, you don't get I'm drifting a little bit, but you've got my flavor on that, yeah.
Thank you so much. My question is around back to the, you drop in to do some work without the longitudinal and the long-term career commitment, and how to kind of develop strategies for workforce development that get your workforce in the right frame of mind, so that as you're preparing the patients to have voice, their ears are in tune. Mm-hmm. And some of that is by experience and modeling, but have you done anything around curriculum development or formal strategies for workforce development?
Boy, that's a great question. And the answer is, other than the healthcare workforce, which we spent a lot of time on, we haven't really done the next thing, which is probably far more important. So what we've had to do is realize that we get involved with the medical students, the residents, we have undergraduates work. We try to get students working, but this is all in the healthcare context. So on our team, we're doing that. And in truth, most of the doctors we hire now, and we have about almost 40 doctors now full-time in our program, almost all of them worked with us when they were undergrads or residents. So it's the best way to train. But you have to build to that, because I realized when I was alone back in the beginning. It took me 4 years before you could find another doctor. And then once we had 2 of us, and you could find one a little bit quicker. And then once we had 3 or 4, you could start to get them. So it's a process. But it is for us, it was a really important one because we buy into this has to be part of the mainstream. It can't be just a fly-by-night, you do it a little bit like that. It should be part of the mainstream just like we expect of any healthcare setting.
Well, I'm sure we could discuss all morning, but thank you so much for your
thank
generous
you
time
very
and
much.
taking questions. So thank you, Jim, really, for all the work that you do and for sharing it with us. And obviously, your pioneering work and vision goes far beyond Boston. So we will continue the conversation here in Scranton. I know you are willing to sign some books, and so if you have a book with you, if you'd like to purchase one, Dr. O'Connell will do that over there. And I do want to also just let you know that next Friday morning, we're very excited to be celebrating the inauguration of our president, Father Scott Pilar. So we always like to see our friends from the community on campus, and of course, we'll welcome you to come back. And the emphasis is really on a celebration of community. So hope to see some of you then, and have a wonderful rest of your day. Thank you again for being here.